Thank you very much. Can everybody hear me okay? I will proceed as if you can. So next slide, please. So just a couple quick disclosures. I get some funding from the National Institute of Health for some work related to stroke and deep brain stimulation. I have some funding from InsideTech that's related to Alzheimer's disease. That's about the closest thing that I have related to this talk for some of the work that we do with focused ultrasound. I do a little bit of outside speaking, but it's really pretty minimal and not related to this topic. So other than my feelings about my mother, I really don't have much in the way of conflict. So just to kind of get that out of the way, next slide, please. So what we're going to talk about today is what we used to call dementia, but has been rebranded as major neurocognitive disorders. We'll spend a little bit of time making a distinction between that and minor neurocognitive disorder or mild cognitive impairment. We'll talk about the major types of progressive neurocognitive disorders and kind of what the clinical phenotypes are, a little bit about the pathology, and just a few hints to kind of keep your eyes out for if you think you might have a case like this. So go ahead for the next slide, please. So the first thing is, what is a dementia or a major neurocognitive disorder? The thing to understand about this is it is a big, broad umbrella category. What it means is that you've had some intellect that you have lost. Typically it's memory, but it could be other thinking skills like language skills, reasoning skills, judgment, or you can have changes in your behavior or ability to regulate your behavior or your emotions. So the first point is you have to have it, and then at some point you lose it. It is not necessarily progressive in nature, this overall category is. Most people think when they think of dementia, they think of Alzheimer's disease, the most common one, which we'll speak of. They assume that all dementias are progressive, but that's not necessarily the case. Some dementias happen because you have loss of cognitive functioning from a single acute event, like a traumatic brain injury or a large stroke, but they don't necessarily get worse after that, and they may actually get better. There are a few cases where you can have a dementia, a major neurocognitive disorder that is actually reversible and that you get better. Those are very uncommon, but that can happen. So you have to have intellect or behavior that changes over time, that gets worse, and it has to lead to some impairment in your life and functioning. If you're a student and you are no longer able to attend school, that would be functional impairment. If you're working and no longer able to maintain your job, that's functional impairment. Or if you're retired but can't get the things done you need to do at home, such as remember to take your medicine, or pay the bills on time, or cook safely, those can all be things that indicate functional impairment. So it's not a major neurocognitive disorder or dementia unless you have some impairment with your functional ability. Next slide, please. If you have these changes with cognitive functioning, but they don't impair your functional status, that's when you're thinking about what's called mild neurocognitive disorder, or MCI, mild cognitive impairment it used to be called. So this can be the precursor to the development of a dementia. In some cases, it's mild and it's not progressive, but in the cases that we'll talk about today, these progressive dementias of typically the elderly, it is the precursor. It's the very beginning of the symptoms as they start to show themselves. That's the MCI, or the mild neurocognitive disorder. It's what's happening as it starts brewing. The changes start happening to the brain. You start to have some symptoms in your life, but they're not bad enough to cause functional impairment. As I say with patients sometimes, they're more of a minor irritant or an annoyance, actually, is what it is. Technically, for this definition, either the patient has to notice it and complain of a change with their cognition, such as their memory. But sometimes we know that patients don't realize this or recognize these changes and symptoms. So it could be a family member who notices this change, or it could be a provider that notices the change. This definition about who can notice the change has evolved over time. It used to be it just had to be a complaint by the patients, but patients don't always notice it. Actually, today in clinic, Dr. Ward and I saw a patient who we think has a mild neurocognitive disorder, And they were sent by their provider who noticed the changes themselves and asked us to evaluate. So somebody has to notice it, patient, family, or provider, and then we actually have to measure cognitive change, whether it's by a screening test like the MoCA, the MMSE, the SLUMS, or more extensive neuropsych testing. We have to be able to measure change that's noticed by somebody else, but it can't be severe enough that it causes functional impairment. Technically, any major neurocognitive disorder, any dementia has a precursor like this. Whether it's Alzheimer's disease, Lewy body dementia, frontal temporal dementia, they all have a precursor. And it just is those initial symptoms as they develop, but no functional impairment. They can still take care of their lives. It's not a dementia, it's MCI. Next slide, please. So the other point that I want to make is when you're looking at and trying to figure out the difference between these various conditions. So you think somebody has changes to their cognition. You can tell it's impacting their functioning. The next thing you want to do is try to figure out what the diagnosis is. Accurate diagnosis leads to better treatment. And so you try to figure this out. Now, the history and symptoms can be very helpful, but it's really important to understand that those clinical symptoms that a patient shows don't translate into exact terms about the pathology that's happening in the brain. The history and symptoms tell us about what's going on and where it's going on in the brain. I always think about and talk to patients and families about the brain being a blueprint. It's laid out, different parts do different things. And based upon the symptoms that a person presents with, you have a sense of where things are going wrong on that blueprint. And based upon complex systems, what systems are going wrong. But that doesn't tell you what's going on underneath at the cellular level that's causing that dysfunction. We don't have a pathology scope that we can bring into clinic and actually see that. We are just going to go based upon odds, so to speak. So the clinical symptoms that we look at tell us the likelihood of an area of the brain or areas of the brain that aren't working. And then based upon odds from what we typically see or the course or other history, we make a prediction about what the pathology is likely to be. So getting the history and symptoms is important because it helps us localize the process. History is everything. But that clinical diagnosis that we're going to end up making is based upon those inferences. And it's also based upon the typical cases and the typical presentation of cases. There are classic cases of patients who come into clinic and you almost know right away what you think that they have based upon that presentation. But you can be wrong because you are not actually seeing that pathology. And as we'll talk about, there are less known and less typical variants of some of these diseases that overlap. There's a variant of Alzheimer's disease that most people don't think about that actually is very similar to frontal temporal dementia behavioral variant. And you only know that outcome when you see that pathology at some point. Go ahead, next slide, please. So now let's talk about some of these different categories of dementia, the most common being Alzheimer's disease. So most common dementia that we see in the elderly, it is progressive. It usually starts very slowly and begins with minor forgetfulness. Those of you who know me know I talk about my family and I talk about my mother who had the disease. And we have this joke running in our family about where are my glasses actually. So I always find this cartoon kind of entertaining. It started with my mom's grandmother who said to my mom when she was young, where are my glasses? My mom said, silly, they're on your head. And she learned not to say that again because she apparently had to scrub the floor back in the early turn of the century with a toothbrush, because that's not how you talk to your grandma. But we've had this problem with losing our glasses. I never put them up on my head because I'll lose them, so they're right in front of me. The most common typical symptom with this is short-term memory. The pathology of this disease is the abnormal accumulation of beta amyloid that forms plaques and phosphorylated tau that creates these tangles. Now, the beta amyloid is something that people talk a lot about, but we know that the tau is what actually kills off the cells and causes the disease. So that's the pathology of the disease. Next slide. Let's talk about the classic clinical phenotype, which is somebody comes in complaining of short-term memory loss. And it's a different kind of memory loss. It's showing signs of rapid forgetting and loss of memory. It's not that it's in there and you can't find it and pull it out, but it's gone and it's gone quickly. It actually disappears from the memory store. And this is due to the tau deposits in the medial temporal lobes and the hippocampus damaging that structure. Clinically, the thing I always look for is patients who are repeating themselves without recognition. So somebody who tells the same story over, that is a big signal and flag to me that says that the medial temporal lobes and the hippocampus are being affected. Now, 9 times out of 10, maybe 8 times out of 10, that's going to be Alzheimer's disease. But we've learned recently with some of the imaging we're able to do that some of these cases, it's not Alzheimer's, it just looks like it. So classic is forgetting information rapidly. One of my mentors taught me that you look and you see if, so an older woman who comes into clinic, you look and you watch how tightly she clutches her purse. Not because she thinks that you're going to take her purse from you, although on occasion my mentor might have done that, but on most occasions that's not it. It's that they don't want to let go of it because if they set it down, they'll forget it. So you look for these signs, these markers of repeating and so forth that tell you that. That's what's going on. As the disease progresses and the pathology spreads to the rest of the brain, you'll see other problems like difficulty finding words or difficulty in space, finding your way around, getting your way out of the store, etc. One of our very recent patients that we enrolled in a clinical trial, she was a nurse and she noticed that she was having these problems because they put her on a different floor in the hospital. And she had trouble finding her way off that floor because it wasn't her typical floor. That was one of her first markers that something was really wrong. Next slide, please. So we use imaging to look at these cases, and I just wanted to show you very quickly that we can actually see these changes to the hippocampus that happen. So the hippocampus, I don't know if you guys can see my cursor here. I hope that you can. If not, it might just be on my screen. But you can see this area of the brain there that is smaller on the right-hand side than on the left-hand side. And that's actually the hippocampus that is shrinking over time that we observed with this patient who went from mild cognitive impairment to full Alzheimer's disease. So we have the technology to be able to see this in some cases. Next slide, please. But we can actually see things better ahead of time, actually with a PET scan that looks at function, not structure. And so if you look at the MRI scan above, you can see a little bit of hippocampal atrophy. But if you look at that PET scan down below, brighter colors mean more activity. There's a lot of areas of the brain that are just not active and functioning and working very well. And we can see this really pretty well in some of our patients. That's kind of giving us a warning sign how bad their memory is going to be. That's a classic presentation, a PET scan for a patient with Alzheimer's disease. Decreased metabolism in the temporal and parietal lobes, and you can see it. You don't have to be a radiologist to see that in this case. Colder colors mean less activity. That area of the brain is just not working. Next slide, please. Now, as I said, patients don't read our textbooks, and so sometimes they present differently when they actually have Alzheimer's disease. There's an executive or a frontal variant, and they show primarily behavior changes. There's a language variant where it's more predominantly affected in the left hemisphere, and they have difficulty finding words, very similar to patients who have a frontal temporal dementia or primary progressive aphasia. And then there's a posterior cortical variant that has a lot of visual changes or agnosias, more similar to what you see with Lewy body. So why is it that they present this way? Well, we don't have an exact answer, but the basic idea is that it's just where the pathology in the brain is accumulating. In most typical cases, it presents and it accumulates in the temporal lobes. And so you get the symptoms in the temporal lobes. But if it's presenting somewhere else in the brain, you can be fooled, so to speak, because it looks like a behavioral problem from frontal temporal dementia, classic Pick's disease, but it's actually not, because the pathology is more heavy in the frontal lobes in this case. So these are the challenging cases. These are the ones that it's harder for us to pick and understand based upon just clinical symptoms and presentation. But these are these are the less classic cases of Alzheimer's, but they are still Alzheimer's. And eventually over time, they will look more like classic Alzheimer's disease. Next slide, please. Now, we have the ability now to measure the pathology of Alzheimer's disease in the brain of living patients. In the past, you could only really see it if you did a biopsy or the case came to autopsy. Now we have special PET scans that we can do that can measure the amount of amyloid in your brain. It's approved by the FDA, and there are new scans that measure the amount of tau in your brain. You can actually do these PET scans and actually say, yes, there is amyloid and tau in this person's brain. And so you can essentially help confirm that diagnosis by this. The picture that's up there on the screen is one of our patients, actually. We enrolled in one of our clinical trials. The brighter colors mean more accumulation of amyloid, and this patient had loads of amyloid in their posterior cortex, in the posterior cingulate there, that helped us confirm that diagnosis for her. Unfortunately, neither of these scans right now are paid for by Medicare. There was a special study that was done called the IDEA study that worked on whether or not we could get Medicare to approve this, and they haven't made a final decision about this yet. So we can't order these scans clinically, but we do them for research. But in the future, it may be for challenging cases, we get this kind of PET scan to help confirm the diagnosis. And the reason that's important is you do a better job treating if you know what you're treating. There's some agents coming down the line potentially to help clear these things out. We don't want to administer those agents to patients unless we know for sure this is the disease that they have, because there's risk associated with them. So just keep in mind, there may be evolution with some of this imaging that we can do in the future to really help confirm this clinical diagnosis that can be tricky at times. The other thing I'll mention real quickly is that we have had patients with Alzheimer's disease, or patients that I was convinced had Alzheimer's disease. And you know, I have to admit that before these scans came out, I was probably getting a little cocky with how well I thought I could do this. And we did these scans and they had no amyloid in their brain at all. And they looked and acted like I was convinced they had Alzheimer's disease. I don't know what they had, but they didn't have Alzheimer's, because you can't have Alzheimer's if you don't have beta amyloid in the brain. And so clinically, I know that it can be wrong. And it was a humbling experience for me, and I keep that in mind. And I try to remind myself of that every day, that we're just going on this clinical phenotype and that can be wrong. So maybe in the future, we'll have better diagnoses, which will lead to better treatment and better outcomes. Next slide, please. So Alzheimer's, everybody's heard about it. It's the most common, maybe 50% of cases. What are the other common types of dementia that we experience and that you might see here in West Virginia? Well, given our health concerns, the rates of diabetes, hypertension, obesity, COPD, we have a lot of vascular dementia. And there's two real types that we want to think about for this. There's the large vessel disease. So you have an acute stroke that takes out a major blood supply to your brain that leads to very focal deficits like hemiparesis, but also loss of cognition. That's an acute, rapid drop-off in behavior, or you could have multiple of these and you have a stepwise progression. That's pretty easy to recognize and diagnose with MRI scans or CAT scans. The history is pretty easy to get. They were great. All of a sudden, they were not. They were paralyzed on the right side and they couldn't speak anymore, and then they had all these problems. That's a pretty clear and easy case to diagnose. The other cases are a little more difficult to diagnose. These are smaller changes to smaller vessels, some very small lacunar infarcts, or just a smoldering change that we'll see to the small vessels in the brain. And that can look more like Alzheimer's disease, actually, because it's gradual, it's insidious, and it's progressive. And it doesn't have that clear decline in function like you can see with somebody who has an acute stroke. So sometimes that will get mistaken for Alzheimer's. But when we do MRI scans, we can clearly see this. Behaviorally, these patients, though, they present with different types of memory problems. They have a lot of more attention and reasoning and speed problems, and some memory retrieval problems. Let me show you real quick a couple pictures so you can see what this looks like. Next slide, please. So over on the left-hand side is an example of a mild case of small vessel ischemic disease, where you just have a few white dots in the brain that may produce very, very small minimal changes. On the right, you have a case of more moderate changes that you're seeing with the small vessel change that could lead to some maybe functional impairment. The one on the left, as you get over the age of 60, everybody's got a few of those dots, and you may or may not have some cognitive change. On the right, you're going to begin to show some mild cognitive impairment. And then if we look at this next slide with really extensive confluent changes to the small vessels all throughout the white matter of the brain, you're going to have significant problems with your functional ability once you show that. So it's a very different kind of presentation than somebody who has an acute stroke, and it can look more like Alzheimer's disease. But actually, it's fairly easy with advanced imaging and an MRI scan to pick this up and see. And so if you have a patient who has a lot of poorly controlled hypertension, diabetes, COPD, maybe they have black lung because they worked in the mines, obesity, sleep apnea, it may be worth considering just going ahead and getting that MRI to see how bad those changes may be. And of course, you can have both diseases, by the way. We have many patients who have changes to the small vessels of the brain who also have Alzheimer's. Okay, next slide, please. So the other kind of dementia that is much more common than we think is Lewy body dementia. I'll tell you that when I started out, this diagnosis didn't even exist. The disease existed, but we didn't really even have a name for it. And then some people started noticing folks that they thought had Alzheimer's disease who also had Parkinson's symptoms. So Lewy body disease is named after these inclusions that you get in the vessels, these Lewy body inclusions that typically happen in Parkinson's that actually spread to the cortex and produce hallucinations, fluctuations, Parkinsonism, not commonly tremor, but maybe gait problems, balance problems. And so this conglomeration of symptoms that you see, along with something called REM sleep behavior disorder, which was added as a core symptom just a few years ago. REM sleep behavior disorder is people who act out their dreams. So typically when you're dreaming, you're in REM sleep, your muscles are paralyzed, so you don't act them out. But in REM sleep behavior disorder, you lose that paralysis, and you may actually punch your spouse in your sleep because you're fighting and wrestling with somebody. I mention this because it's an easy, quick question to have if somebody has Parkinsonism that may give you a hint as to whether or not they are developing or may develop Lewy body disease. Now, other diseases will have REM sleep behavior disorder, but it's highly associated with this. So it's a quick, easy symptom to ask in somebody who has a developing dementia, just like are people repeating. Now, not all patients have these core symptoms, but it's much more common than we think. And so when I talk about these dementias, I always think about who are famous people that have them. And we think the most famous person that people know about who had this disease was Robin Williams, who actually took his own life. And that's an important lesson for people to have because there's a huge behavioral component to this. It's not just hallucinations and delusions, but there can be disinhibition and frontal dysfunction and significant depression and anxiety. So there's a significant risk with some of these dementias for people taking their own lives. So that's much more common than we think. And another marker to think about with this disease is typically with Parkinson's patients who get dementia, they have their movement disorder symptoms for many years before they develop the cognitive and other symptoms. With Lewy body, they all clump together in time. They're much more likely to happen rapidly. With classic idiopathic Parkinson's, you don't get the dementia for years. But if somebody's developing these hallucinations, cognitive changes, and then they get Parkinson's later, that's a big warning sign for this. And sometimes the symptoms are actually responsive to some of the medications. Next slide, please. So the next group and the final group that we'll talk about here are the frontal temporal dementias. By the way, there's a ton more, but just to hit these major categories. Originally, this was thought of primarily as just Pick's disease, which was identified by Arnold Pick. And the inclusions in these cells are called Pick body inclusions. So it was originally thought that this was a specific disease that affected the frontal lobe that resulted in behavior change. This category, this broad category, has been really broad, and it includes Pick's disease, but it's a much broader category. And it involves any or all of the frontal and temporal lobes, which is big territory in the brain, much more than half of it. And the disease that you see, the symptoms that you see, depend upon where it starts in the brain. And so where it starts tells you what the symptom presentation is like. There's a whole bunch of different pathology. It can be tau pathologies, but there are many others. Some of these share genetic traits and genetic markers, but it can be really messy. So if you go to the next slide, we'll talk just a little bit about this. So for example, if the pathology starts in the right frontal or temporal lobe, or bifrontally in the orbital frontal cortex, you'll get behavior change. And that's more typically the classic behavioral presentation for this disease. But if it starts in the left frontal lobe, in the area near Broca's, you will have somebody who presents with what we call a primary progressive aphasia. People can recognize aphasia from stroke because it's an acute onset and decline and loss of language skills. But some of these patients have this gradual progressive loss of just ability to find and get words out. And that can be from this frontal temporal dementia, primary progressive aphasia. If it's in the temporal lobe, it's more loss of knowledge about semantic aspects of language or comprehension rather than word finding and getting those words out because of where it's starting. And you will have patients who start with one of these and evolve into these. You will have patients who have behavioral presentations along with language presentations. And then there's a whole host of these frontal temporal dementias that involve motor variations and motor symptoms. Most people, when they think about ALS, and for a long time when they thought about ALS, they thought about the muscle weakness and the loss of motor skills. I always conceptualize this disease as something that is associated with the motor cortex. The motor cortex is the most posterior part of the frontal lobe. And so there is rarely an ALS patient that you see who doesn't at least show some frontal signs. And a larger proportion than we realize show a frontal temporal change or frontal temporal dementia. So it's much more common than we realize as we started to look closer at these patients who have ALS, which is a terrible disease to have, but will have behavior change and behavioral disinhibition that goes along with it. But you'll also see variants that have Parkinsonism or Parkinson's-like symptoms like progressive supranuclear palsy, cortical basal syndrome, or multiple system atrophy. Some people conceptualize those Parkinson's-like diseases as actually FTDs. So this category gets bigger and bigger every day, but how it presents depends upon where that pathology is. And if it's presenting subcortically initially, you're going to have a Parkinson's-like presentation, but it may also involve the frontal cortex with a lot of behavior change. Next slide, please. So if you can't tell, I love pictures and MRI scans, and these are classic pictures that show the behavioral variant of frontal temporal dementia on an MRI scan. Anybody can see how atrophied that frontal cortex and that temporal cortex is becoming. It's an easy diagnosis when you see this and you see the behavior change. We don't see these cases very often, but it's a classic presentation. Next slide. And then finally, here's a PET scan of a patient that we saw here who we thought initially had bipolar disorder. But when we got the PET scan, we could tell this was a terrible frontal temporal dementia with no activity in the temporal cortex or the frontal cortex. They had essentially shut down in this case. Unfortunately, this patient went on to later develop ALS also. So you can see that happen. Terrible case. Classic presentation, no activity in these areas. But we don't see these classic cases very often. Next slide. And then if you're looking at a primary progressive aphasia, here I'll remind you on the middle slice that left is right and right is left, you can see that atrophy much more in that left hemisphere. And in this case, that atrophy in that frontal cortex there, a little bit in the temporal cortex, but primarily in that frontal cortex. It's like there's a hole there, and no wonder they couldn't get their words out. Classic cases, but we will see these cases presenting. Next slide, please. So what are the takeaways? History and symptoms are going to tell you about the areas of the brain that are not working. Sometimes you can figure out the pathology just based on frequency and odds, but you have to remember that you'll get that pathology wrong sometimes because patients don't read our textbooks and they present differently. Using advanced imaging and other biomarkers can increase the chances that you can make a more accurate diagnosis. If they show that classic PET scan presentation, or you can see the atrophy on the MRI, it's easier to make an accurate diagnosis. That gives you better information to tell patients and families, as well as for treatments going forward. But it helps you educate them better so they know what to expect and know how to manage things. And it helps you know what treatments are more likely to respond for these particular patients. We hope that we're at a place in the near future that we'll be able to make the most accurate diagnoses that will lead to better treatments for these patients. If in the near future we're able to prescribe amyloid clearing agents, it's going to be really important that we get that diagnosis correct, because you don't want a patient to undergo an infusion that has a lot of risk to the brain unless you are convinced that they actually have amyloid in the brain, and there'll be those protocols in the future. So hopefully we'll get better at this, but right now it's clinical experience that tells us most often, and you have to be humble enough to know that sometimes you're going to get that case wrong. Okay, I'm going to pause and see if anybody has any questions that I can answer for you.
Thank you so much, Dr. Hout. That was awesome. Super thorough, and I love the images that you included in that as well. Did anyone have any questions for Dr. Hout, the didactic?
I do. I was just wondering, on those patients where you did get the PET scan, how were you able to get that approved?
So all the amyloid scans that we have done here are not approved and not paid for. And so we either pay for them out of a research fund because it's part of a research project, or occasionally families will pay for it out of pocket. And it is pricey, I will tell you, to get that done. But some people really want to know. So research funding to pay for it, or families will pay out of pocket. Now, getting a standard clinical FDG scan is indicated in many cases, and you can get that approved if you are unclear about that diagnosis. It takes us a few hoops to get that approved, but we can make that happen. And we order those for some of our patients that we are unclear about the diagnosis based upon our initial evaluation, MRI, clinical history, and their presentation. We will get a PET scan to clarify that diagnosis, actually. After this echo today, we have our consensus conference where we discuss all our memory patients, and we're discussing a patient who we got a PET scan on to help clarify that diagnosis. And I will tell you, the reason we're presenting them is because it didn't clarify the diagnosis. It actually showed something we didn't expect. And so it's going to lead to further discussion about how do we get this diagnosis now in this case. Clinical presentation was different. MRI was different. PET scan, it's something different yet. So sometimes we get more questions than we get answers. But we can get PET scans approved by most carriers to help with the diagnosis.
Thank you. Jen, was there something you wanted to add as well?
Yeah, I have two questions, and also thank you so much. I mean, I have so much to learn, and this was really great. So one question is, in frontotemporal cases, is the pathology there? Is it just atrophy, or is there anything else?
So the pathology is different. There's probably about 5 different pathological subtypes that you can see.
Okay.
But essentially what's happening is you are having some abnormal proteins that are building up in the brain. Oftentimes it's tau, but not only tau, that's accumulating and killing the cells off. And that leads to atrophy.
You might have said that, but I didn't absorb it, so thank you.
So technically, it can be a number of different pathologies, but the practical purpose is eventually it leads to cell death and you get atrophy.
Okay.
By the time you're seeing that atrophy, it is down the road, I should mention. Anytime you see the atrophy in the hippocampus or in the frontal lobes, they are well into the course typically. You can
Okay.
see the changes on PET scan as they're just developing the symptoms. You can see that functional change earlier. When you see the atrophy, not in all cases, but most cases, it's heading down the road.
Okay. And then one other quick question. I want to make sure that I understand this. So there's dementia associated with Parkinson's disease. And with Lewy body dementia, there can be Parkinsonian symptoms or signs, but the dementia of Parkinson's is not Lewy body dementia. Is that correct?
Okay, so you can have, so all of those are technically classified as alpha-synuclein pathology. So
Okay.
they often have these inclusions. It's where the inclusions are and how much they are that cause the problems. So originally these Lewy inclusions were initially seen in Parkinson's patients subcortically, and they noticed them in some patients cortically, and then they said, oh, they have a dementia also. So it's where that dementia, where the pathology spreads that causes the problems. And to some degree, it's when it happens. So the difference between Lewy body and Parkinson's dementia is the history and the time course of that onset of the symptoms other than motor symptoms. Does that make sense? Classic Parkinson's patient, tremor, rigidity, bradykinesia, respond to dopamine. 10 years later, cognitive problems. Lewy body patient, maybe it's problems with gait, maybe it's falls, not much tremor, and that happens after they develop cognitive symptoms and hallucinations. Then it pops up.
Yeah, gotcha. Very helpful.
They may still respond to the sentiment though, actually.
Yeah. Super helpful. Thank you. And then for Jay and Mitra, it would be helpful if there were a pointer, if we could get a pointer for the images, because they're wonderful. And if we're not used to looking at them, we might not know what to see.
Yeah, we'll let the presenters drive next time so they can use their
Oh,
cursor. We're
awesome.
not used to all
Okay.
these images.
Yeah, great. Thank you.
Yeah, the images are new to us as well. But great point, Jennifer. Thank you.
Yeah, thanks. I didn't think about that. I'm used to just showing it with my mouth, and then I realized, oops, I don't have control of that.
You did a great job describing it though, so thank you for that. Any other questions or thoughts, comments for Dr. Hout?
Hi, this is Donna. Dr. Hout, I'm just gonna say my husband was 59 when he was diagnosed up at the ADRC up in Pittsburgh, because we live in Pennsylvania. They've been very wonderful. So we've been following with them for 8 years now. And he was diagnosed with what they thought originally was the supranuclear palsy, because he was falling. I was coming home finding him passed out, and they thought at first, his PCP thought he had a stroke. And then Dr. Lopez up there is who we saw and did come up with that diagnosis. But then when I started, I'm a nurse at WVU Medicine now, so when I came down there, I did see your department, the neuro department there at WVU, and they did switch him to the temporal frontal dementia, feeling that was more accurate. He's had a slow progression, but I've noticed, and he often thinks he should just, like today, he said probably 3 times that he should just die. He's forgetting more and more and more. So it's been very frustrating. And he did have the PET scan up at Allegheny General Because at that time, he still has a wire in his heart from a pacemaker that is no longer there, but he can't have an MRI. And I think it was that we were at the memory clinic there at WVU Medicine last year. And they tried to get a repeat PET scan just to see if there was a, increase in the problem. And I still haven't gotten that approved. So he still has not had a repeat one. So it is hard, it seems like, to get things moved along there to even see. And I, too, was not used to looking at these images, but Dr. Lopez was able to point out to me, and it was very visible 8 years ago to me. And that's when he told me, this is what he has. Look at the pictures. And that was very helpful for me. I'm a nurse, but again, I wasn't familiar with that. So he was very able to show me what was happening to my husband.
Right. So I'll a couple things real quick in response to what you said. Thank you for sharing. One is that getting repeat PET scans is harder because they're willing to pay for it up front to help with the diagnosis, but not to track progression. So I understand why that's a struggle. The other phrase that we have that we use sometimes is, if you're patient, things will reveal themselves and the hand will reveal itself. And so what those initial symptoms are may not be what is clearly evident, a different type of disease later on. So somebody may start with those falls and things that look like PSP, but actually may be an emerging frontal temporal dementia that you can clearly see later on. And we've seen that happen. The first patient I ever saw with a primary progressive aphasia started out with word finding problems, but they evolved eventually into a full frontal temporal dementia, and language was not the only problem. And we could see that evolve over time on the MRI scan, so it didn't stay. So if you're patient, it will reveal itself, but patience is hard for us as clinicians, but also as providers. Okay.
I want to thank you for all you're doing, because we definitely are looking, when you guys started the Alzheimer program there, we certainly signed up to get involved in it, and he's definitely a donor up at the DRC, so we definitely appreciate all your progress.
Well, thank you everybody very much. We appreciate your time, and we look forward to seeing you again in the near future.
Thank you so much. So a couple housekeeping announcements. We only have a couple minutes left here of the session, so I wanted to say a few announcements before we part ways. So we will keep the next session, which is November 3rd, and Dr. Mark Miller will be discussing person-centered care. So keep an eye out for that reminder. We are also going to be sending out a recap email after every session that we have. We will be with the YouTube link that will take you to the recording from today's session. And in particular, today's recap email, we are also including a survey that will sort of gauge the comfort level in managing care of patients with memory health conditions and sort of the goals of this project, so that we can best tailor this project to participant needs and everything like that. So thank you again so much for joining us for our first Memory Health Echo session. It was super exciting, and I want to give a big thank you to Dr. Hout for the awesome didactic and answering the questions and everything. So thank you all so much. I hope you have a wonderful evening, and we will see you guys next time.
Thank you.
Thanks, everybody.
Thank you.